Okay. So my goals really are to discuss three types of cannabinoids: the endocannabinoids in humans, the phytocannabinoids, and then also the synthetic cannabinoids and their medical importance. We'll also talk a little bit about the lingo for cannabis products, or the language involved, also the formulation, the routes of administration. In the potency. 2 points I hope to make. One is that legalization of cannabis, certainly in the US, does not mean lack of harm. It basically means a lack of information at this point, in that exogenous cannabinoids may alter the normative trajectory of brain maturation, which is important, obviously, in pediatrics and adolescents. And if time, we'll talk about some of the signs of cannabinoid toxicity. Now, the public health of benefits from legalizing cannabis in the US, I think, are certainly important, can reduce the stigma and realization of the potential therapeutic benefits from cannabis. It also the use of cannabis for therapeutic purposes should no longer result in the fear of legal sanctions in the US. Although this next point is controversial, the reduction in opioid, there may also be reductions in opioid deaths with legalization of medical cannabis and the availability of the numerous dispensaries. And then finally, the removal of various blockades for generating research for various cannabinoids. Currently in the US, cannabis is a Schedule I substance under federal law, and making it very difficult to do any form of research in that state. So why do adolescents smoke or use cannabis? Well, like everyone else, it has to do with the THC, which is the principal psychoactive component of cannabis. About 18% of Americans aged 12 and over use cannabis. The majority of any new user is going to be under the age of 18 years of age or in the adolescent age. And cannabis use has increased among the youth since 2007. Of importance, THC targets the endocannabinoid system of humans, and the endocannabinoid system regulates biological processes in terms of development and neuroplasticity. Exposure to THC during critical periods of brain development has the potential to disrupt the tightly regulated system, specifically the endocannabinoid system, which can result in behavioral issues and psychosis. Also during pregnancy in the US, about 2 to 5% or upwards to 15 to 28% of pregnant women utilize cannabis for purposes of nausea, vomiting, stress, and pain. The percentages that use it are a little bit unclear, but at present, both the American Academy of Pediatrics as well as the American College of Obstetricians and Gynecologists do not recommend using it, and at present, it's not listed as a teratogen. In terms of breastfeeding, THC is concentrated in breast milk by about 7 to 8 times that of in the serum. In terms of tangible harms, we don't know. It's really unclear. The three types of cannabinoids. First one is endocannabinoids, which are brain-derived in humans, consisting of anandamide and 2-arachidoyl glycerol. These are arachidonic acid derivatives. They are not stored. They are not stored in vesicles. They're synthesized on demand, and then they're rapidly metabolized locally. The synthetic cannabinoids are chemically engineered, whereas the phytocannabinoids are plant-derived. First, the phytocannabinoids, they're terpenophenolic 21-carbon compounds derived from the cannabis plant. Cannabis, again, refers to dried leaves, stems, seeds from Cannabis sativa or Cannabis indica plant. The more common forms of the phytocannabinoids are the delta-9 tetrahydrocannabinoid, or THC, and that is the principal psychoactive phytocannabinoid. And then another phytocannabinoid or cannabinoid is the cannabidiol. And of course, there are many, many others that we really don't know a lot about. The cannabis concentrates consisting of THC or CBD and others are produced from trichomes, and I'll show you what a trichome is. And trichomes are the glandular appendages that are outpouching from the leaves that appear white or clear, kind of like fine sugar that's sprinkled on the leaves. In cannabis, concentrates can be either solvent-based or non-solvent-based, and these typically are the more highly concentrated THC. Shown here is a little bit of the anatomy, simply showing on the slide on the extreme left is a cannabis plant, and then going from left to right, the extreme right showing trichomes, which are the glandular white or clear processes sticking out from the leaves, and that is where the highest concentration of cannabinoids come from. As an example, hash, which is the oldest form of cannabis, is composed of purified trichomes. In terms of the endocannabinoid system in humans, the endocannabinoids and receptors are produced naturally. They occur at specific and correct times and correct amounts for normal development. These endocannabinoids, as previously noted, are produced on demand. And the two principal signaling molecules are shown there as well. Now, endocannabinoids, as I've mentioned, are produced on demand in the postsynaptic neurons. They act as retrograde signaling messengers that modulate synaptic release of the neurotransmitters, of which there are many. The cannabinoid receptor 1 is the receptor that's primarily in the nervous system, and cannabinoid 2 receptors are primarily expressed in immune cells, and I will not be talking about CB2 receptors. And finally, the third cannabinoid that I'll be talking about is synthetic cannabinoids, and this will be very brief. These are chemicals that mimic the effect of THC at the CB1 receptors, but they are extremely high potency, anywhere from 10 to 100 times the potency of THC. And these chemicals typically are just sprayed onto natural herbs or mixes or vegetation and then smoked. These, again, have been created as unregulated alternatives to cannabis. They were initially developed by academics in the 1970s to explore the endocannabinoid system. The desired effects include relaxation, altered mentation, disinhibition, but the effects can be very different from natural cannabis. Again, as already mentioned, they're highly potent, used as legal highs, and there's well over 500 synthetic cannabinoids now that have been documented. And the adverse effects are plentiful, shown here. In terms of the cannabis forms and their relative potencies, at the top, we have the low to medium potencies, and then all the way on the bottom, the very high potency. Low typically has been the flower, bud, or leaves, and these typically are inhaled through various processes, pipe, bongs, joint, blunt, spliff. These are terminology in terms of the blunt and spliff, is which both tobacco and cannabis is used, and these work synergistically, which have obviously rewarding effects and addictive effects from tobacco as well as THC. Moving down in the low to high process is edibles, and edibles include baked goods, frozen goods, gummies. These, however, are not titratable in real times because the effect emerge about 60 to 90 minutes after ingestion, unlike inhalation, which generally occurs in about 10 to 15 minutes. And then at the very bottom, we have the concentrates, the non-solvent based and the solvent based. The solvent typically used is butane, which is flammable, which is inherently dangerous sometimes, obviously. And these consist of, as already mentioned, hashif or keef, rosin, wax, and then the butter shatter. These are all just terminologies for highly concentrated THC products that typically many adolescents as well as adults use. Now, there's been a changing landscape of the cannabis potency through the years. Going left to right on the x-axis from the 70s to the 90s, that's been fairly stable. And again, we're talking primarily here of cannabis leaves being about 10% THC concentration. And then moving on in years up and through 2020, you can see a general change in the increase of THC concentration upwards to 30 to 40% in terms of cannabis leaves. One of the issues has to do with the significant changes in this cannabis potency over the past decades have resulted in a disparate neurobehavioral outcomes and data that does not reflect the potencies used in the studies performed in the 20 to 40 years ago. And so the question remains whether those studies are really very accurate given the changing cannabis landscape and potency. In terms of adolescent use of cannabis, the expectations are, the euphoric effects, the high, and that's what drives its use. Is mentioned, relaxation, euphoria, perceptual alterations that can enhance the everyday experience. The peak effects are generally 30 minutes, but they start to feel the effects in 10 to 15 minutes. And the adverse effects consist of anxiety, panic attacks, psychotic symptoms, diminished alertness, memory issues, psychomotor problems. But again, not everybody experiences these. In terms of the routes and modes of use, smoking cannabis is, again, the most common mode in youth, and the means by which to smoke them are shown in front of you. Edibles are less popular among the adolescents, but it's growing. And the adolescent use, as already noted, can be associated with anxiety, depression, addiction, and psychosis disorders. But again, most youth who use cannabis, as well as adults, will not develop signs or symptoms of psychosis. This is a schematic overview of the developmental patterns that occur in the endocannabinoid system in humans, looking at the pattern of expression. At the very top, going left to right, is showing gestation, followed by birth, infancy, adolescence, and adulthood. Again, the gray areas show the degree of expression. The very top, CB1 receptor, followed by beneath that are 2AG and 2AEA, which are the two primarily lipid ligands, 2-arachidonyl glycerol, as well as other ligands. And in particular, you'll see that if you look at the very top gray under adolescence, you can see that this area is characterized by a highest degree of cannabinoid receptor expression or concentration. But it's important to note that the changes that occur during gestation up and through adulthood for all of these areas. The bottom panel shows several of the neurodevelopmental events which occur and are regulated by the endocannabinoid system. The adolescent period is characterized by synaptic pruning, shown again in the bottom panel. THC binding to receptors can disrupt this natural interaction required for normal development, which is problematic. And evidence is still being developed to show this. Next slide is showing the distribution of cannabinoid 1 and cannabinoid 2 receptors. And again, I won't talk about cannabinoid 2 receptors. And this is simply showing the distribution of the cannabinoid receptor in the human brain. The regions of the highest distribution of cannabinoid 1 receptor is shown by the named regions. The red X's and those particular areas indicate high levels of cannabinoid receptors involved in the reward system and are thought to be involved in addiction. What's underappreciated in adolescence is just how much remodeling occurs in the prefrontal cortex. The prefrontal cortex is where our ability for concentration or higher cognitive functions, decision-making, controlling impulses occurs. Now, looking at the evidence for adults in terms of psychotic symptoms, what is the evidence in adults for cannabis-induced transient psychotic symptoms? So this is a forest plot with a number of studies. There's 15 studies shown on the left involved in the production of this forest plot, in which it's simply showing these psychotomatic symptoms following infusion in human subjects of THC relative to placebo, in subjects. And the psychotomatic symptoms that they're looking at is disorganization of thought, poor attention, affective blunting, somatic concerns, hallucinations. Again, these in motor retardation, these are symptoms or signs that can be associated with psychotic symptoms that ultimately can also be very similar to schizophrenia. And if one looks at this, the overall result is that a large percentage of people do show these symptoms with the infusion of only THC by way of intravenous So what about the increasing rates of cannabis-induced psychosis in Denmark? This is data from Danish National Registry, so the whole country of Denmark, looking at the incidence rate of cannabis-induced psychosis. And from 1994 to 2006, you can see that it's the incidence is relatively stable. And then starting in 2006 through 2016, there's a threefold increase in the rates of cannabis-induced psychosis. Not shown on this slide, but also from the same paper, is a similar graph. In fact, it's superimposable upon the graph that's shown before you, showing the incidence of schizophrenia as well as cannabis use disorder, again, in adults, and that there's also roughly a threefold increase. And the question is why? Well, some of the feelings are that it has to do with the increased frequency that people are using cannabis, as well as the increased potency over the last 10 to 15 years. The increased potency in Denmark regarding cannabis has gone from 13% up to 30% THC. What about cannabis increases the risk of schizophrenia in adults later in life? What's the data on that? Well, if you look at several of the meta-analysis, these have shown that exposure to cannabis increases the risk of schizophrenia 2 to 4 times baseline. And this is based on whether it be by study design, looking at cohort studies or cross-sectional studies, or by outcome measures, that being psychotic symptoms or diagnosis of psychoses. Again, the increase in adults appears to be 2 to 4 times that of baseline for schizophrenia. Now, the increased risk of psychosis in adults appears to be related to daily use as well as more potent cannabis. Shown here, looking at the odds ratio of developing increased psychosis with daily or higher potency cannabis. The odds ratio shown on the y-axis, on the x-axis, going left to right, showing increases, the effects of increasing either the frequency of smoking cannabis or the potency of what you're smoking regarding THC. And at the very end, you can certainly see that daily use of THC in terms of smoking, as well as the highly more concentrated, in this case, it's greater than 10% THC, what that has resulted in terms of increased onset of acute psychoses in adults. Now, in terms of adolescents, a lot of the data we simply don't have, but the epidemiological evidence linking cannabis to long-term risks of psychosis is certainly beginning to be shown. There is evidence for association of cannabis potency and psychosis and cannabis use disorder as well. But again, there is no cause and effect. These are all associations. The impact of cannabis legalization in the U.S. in terms of the healthcare system, and again in adolescents, is simply showing that cannabis legalization is associated with an increased risk of psychosis in the ED visits, which is the emergency department. Chronic cannabis use is associated with an increase in acute psychoses. And the higher potency cannabis is associated with increased risk of mental health issues. The association between cannabis cognition and psychiatric issues in adolescents is complicated, and there are many factors thought to be involved in terms of the age of initiation of use of cannabis, the duration and the rate of cannabis use, the composition and potency, which we talked a little bit about, and then obviously the presence of many genetic and environmental vulnerability factors certainly play a role. So it is complicated. There are other implications of adolescent health and development with the use of cannabis, certainly academic performances. There are now 4 large epidemiologic trials that simply show that dose-dependent reduction in high school completion and in its degree. In Colorado, since the legalization, cannabis school suspensions have increased from 17 to 23%. Mental health issues, obviously driving is another issue. So what do we generally tell, or what's the advice for adolescents, for those who currently smoke or use cannabis? Well, they should really be told that there are many adverse cognitive, neural, and educational effects from daily cannabis use. Cognitive recovery after cessation, and this pertains to daily users, is likely, but it's unclear with the higher potency cannabis because we don't have the data. Another point that generally we recommend is that to delay the initiation of cannabis use for those who simply are going to use cannabis till later in adolescent years. And it's important to note that the more potent daily cannabis, for which we really don't have a lot of good data on, its use appears to be risky, and it's better to use infrequently. Talking a little bit about cannabis during pregnancy, with legalization comes decreases in the perceived risk of cannabis, and this is one reason why people are apt to use so much more, including adolescents. With legalization in Colorado, cannabis-involved pregnancy hospitalizations are increasing. Recent retrospective cohort study involving monitoring meconium from births involving infants born have found, for those positive for THC, have found lower birth weight, smaller head circumference, smaller length. The meaning of this is unclear, but obviously this is not a normal. And so we're currently under a lot of research looking at this. In terms of the effects of cannabis use during pregnancy, again, some of the understanding of the potential risks are lagging because we don't have the data. Recently, just last year, California DARTIC, DARTIC stands for Developmental and Reproductive Toxicant Identification Committee in California, added THC and cannabis smoke to a list of chemicals causing reproductive toxicity. And from their paper, they state data indicate that THC can interfere with the endocannabinoid system's role in critical events such as implantation, immune system development, bone growth, and neurodevelopment. There is animal evidence showing that studies of cannabinoid receptor agonists induced molecular alterations provide deep biological plausibility at the mechanistic level for the cognitive, behavioral, and motor impairments observed in animal studies after prenatal exposure to THC. And the thought is that this same process may occur in humans. At present, cannabis is not listed as a teratogen. There are many opportunities and research in cannabis, especially in the US, should continued legalization occur. Some of the many potential areas are shown here, but there are a large number. In terms of cannabis and pediatric, its effects on pediatric brains, the summary here is that legalization of cannabis will likely bring with it research opportunities as well as an increased number of cannabis-related disorders. I hope I've shown that endogenous cannabinoids in the receptors are produced naturally in humans and in animals. However, there is much unknown regarding the impact that exogenous cannabinoid agonists have in growth and normal development. The endocannabinoid system has many physiologic roles, including maintenance of pregnancy, reproductive functions, somatic development, regulation of the immune system, and neurodevelopment. And the last point would be that there is a deep biological plausibility for cognitive and behavioral impairments to occur at some level, in talking in terms of adolescents, from the impact that exogenous cannabinoid receptor agonists have on the endocannabinoid system. And with that, I will end.